How I know that POI is making a difference is from some of the stories that I'm hearing from the community. An example is at one of the residential care facilities that POI has been working with. We've heard it. One story was that since the POI team have been going in and providing coaching and mentoring to the residential care facility staff, they've been able to approach these important conversations about death and dying in a much less stressful manner. They are much more empowered to do so. If someone becomes very unwell, it might well be entering the final stages of life, their previous knee-jerk response was to send these people into hospital where they would be cared for by a whole bunch of strangers, but now staff feel empowered to be able to look after the patient in their own setting, which, if you think about it, is the home setting for this patient who may have been living there for months, if not years, and it's much nicer to be looked after by people that you trust and know, and also to be amongst people that you might consider as friends. One of the side benefits of this is that if somebody does pass, if somebody does die in a residential care facility, what used to happen was that the people that were left behind, the possible friends of the patient, they'd be wondering, oh, what's happened to Bob, for example? He was rushed off to hospital in the middle of the night and then he's never come back, and nobody says anything about it. But now what we hear is that people do have a better understanding of what's going on in that setting. So if somebody does die, they do have little remembrance services. There might be a little table to commemorate the person who has passed on, so that the people who are still in that private hospital setting, for example, will be able to think, okay, so if I get really unwell, I'll be looked after, preferably here in my home, and if I do die, I will be remembered. I'm not just going to disappear in the night and no one will know me anymore. So I think that's one difference that POI has been making, and it's a good one. A GIPSI is a GP with special interest, and for the purposes of POI, it will be special interest in palliative care. So we have been training people to become GPs with special interest in palliative care, and this is either a 6-month or a 12-month clinical immersion in a palliative care setting, mainly in the inpatient unit. And people who are applying for it are GPs, established GPs and practices, or GP trainees, GPEP trainees who are coming through the GP specialist training course. And what we have been doing is creating a new workforce of people who have a higher level of palliative care capability and capacity, who will be working both in their own general practices, but may also be helping the POI program in other settings, such as becoming POI GIPSIs, who will be going into general practices, coaching and mentoring fellow GPs in order that they can do things like the palliative pathway activation conversations and other difficult conversations. So these folk will have a role in the community as another layer of better support in the community, because specialist hospices will never have enough staff to serve the whole population. What we're needing to do is better prepare primary palliative care in the community to better service the whole population. So it's just extending our net, making our team bigger so that our communities are better served. So what we have tried to do is provide a consistent regional approach so that there is one regional recipe to get into the palliative care system. But that being said, it still allows for local flavours to be carried out within each hospice, local DHB setting as well. So what we're trying to do with POI is not replace or take the place of what is already in existence, but we're trying to supplement what is already there, trying to add value to the whole system and making it much clearer for the practitioners using the system. And another innovative thing that POI is doing is that we are creating greater capacity and capability for primary palliative care, and we've been building this up over the past couple of years, and we intend to continue growing this because specialist palliative care hospice providers such as myself, we will not be able to cater to the needs of the growing ageing populations around Auckland, so we need to empower our community care partners such as general practice teams, residential care facility teams, in order that we can all provide better palliative care to our community. The tools that we are using for POI have got a great evidence base and are being used in other palliative care settings around the world, including the United Kingdom, Australia and many other countries. The first one that we have introduced to the Auckland region is the SPIC tool, the Supportive Palliative Care Indicators tool, which allows for quicker identification of palliative care patients. We also have the Australian Karnofsky Performance Status tool and the Phase of Illness tools. And what we are trying to do is create a common language throughout the Auckland region, so regardless of the setting, be it in a specialist palliative care inpatient unit setting, in a GP practice, in a residential care facility setting, or even at the local public hospital setting, we will be able to use the same language which allows us to convey meanings much quicker. In one sentence I could say, for example, a person's got an AKPS of 90% and they are stable. That one sentence gives a lot more meaning than a whole paragraph of statements.